So what about newly diagnosed patients where the surgeons are not able to take care of them? Dr. Pavlik, what do you use in your patients that are BRAF mutated who present for therapy?
I usually don't look at a BRAF mutation as a guiding tool as to what I select. I normally look at how the patient presents, the volume of disease, the pace of the disease, look at their LDH, looking to see if they're symptomatic and if they have brain metastases. If they have brain mets, many times I'm going to pick a BRAF inhibitor. But if they have like low volume disease, low LDH, and they have a good performance status and they're asymptomatic, I'm going to go with immunotherapy first.
Do you agree with that, Dr. Joseph?
You know, I totally agree with that. Although I'm even starting to challenge the dogma of the fast-paced disease needs to go on targeted therapy first. And I think that's, you know, we've had, at least with ipilimumab, I think that was a problem. At least retrospectively, LDH levels and things have looked to be poor predictors of benefit with ipilimumab, but I'm not sure that's the case with either PD-1 agents or combination immunotherapies. So, so maybe the dogma is slightly changing that, you know, maybe all patients could be able to start on immunotherapy first and not just the ones with high volume, low volume disease.
And we've seen that in our clinic. I think one of the outdated dogmas about immunotherapy is that they take time to work, but not all immunotherapies now we're seeing. Correct. With the advent of the anti-PD-1, anti-PD-L1 drugs, that you may have rapid and durable response, and the indication that combination therapy can give you not just that, but also a significant tumor decrement, which is what we've only seen with targeted therapies.
And I think what we're really saying here, and I think we would all agree here, is that we know there's only one class of agents that are going to provide a long durable remission, and so we want to give those drugs sooner and as early as we can.
Great point. So, Dr. Kaufman, what if you have a patient who's come to see you, but it's already been started on BRAF therapy? What do you say to them? What's the optimal timing and duration?
So we struggle with this every day, so I think this is a really difficult clinical scenario. So, you know, typically I think we don't like to take patients off, especially if they're getting a benefit. And so we usually will get them to a re-imaging point, and if they're continuing to respond, we tend to keep them on it. You know, I've had some patients actually ask about coming off at the 6-7 month mark because they've heard that maybe that's the right thing to do. And I think until we have clinical trials to support that, I think it's very difficult to remove the patients from the study. So you know, I try to certainly tell my patients that they should maximize the benefit, and we'll be ready to go with something else at the time that we need to.
And the patients that show up and you have to do BRAF targeted therapies, and you choose BRAF targeted therapies, is it single agent or combination?
I mean, so I think at our center we tend to start with single agent. I think that's just kind of been what we've done, but I think you can make an argument for starting with the combination agents now.
Dr. Joseph, you agree?
I think the data is becoming more and more mature that the combination is better. I think at first, I think we were really excited about the combination, and then the CombiD trial came in, and there was a minimal improvement in progression-free survival with dabrafenib versus the combination dabrafenib and trametinib. But now there's been more data that there is an overall survival benefit with the combination. So I think what I like to do is give the most effective therapy first. However, I do recognize that it's more toxic. It's not easy to give. I really do not enjoy managing pyrexia. Gives me and my staff fevers actually thinking about that. But you know, there's not a real great way to actually algorithmic way to handle it either. So
sure. Dr. Pavlik, combo, single, how long?
Well, all the questions, huh? again, I have a tendency to start with dual targets, but sometimes, again, depending on the patient's performance status, depending upon their other comorbidities, sometimes I'll start with a single agent just to see how they tolerate it. How long? I wish I could give you that answer. I watch patients closely. I scan them every couple of months. If they're going to continue to respond, I keep them on it. If I start seeing that they're having some progression, I pull them off faster than I would if they were stable.